Hey guys, we've all seen a chest x-ray, but if it doesn't have the label AP or PA on it, can you tell what projection the image most likely is? In this video, AP versus PA chest x-ray and how to tell the difference, I'm going to show you a simple way to tell AP versus PA in seconds so that you don't get fooled by things like thinking the patient has a bigger heart than normal on a typical portable chest x-ray. We'll also walk you through the chest x-ray interpretation and how to read the chest x-ray and apply it clinically. Hey guys, I'm Dr. Busti and welcome to another topic on This Is Why, a show that helps healthcare professionals transform their medical knowledge from not only knowing the facts or the what, but understand the why and what we do every day in clinical practice. Okay, let's get started. So as in all of my medical education lectures, we need to understand the why. So our first question is, why does the image projection even matter? Well, first, because the portable chest x-ray is one of the most common chest x-ray images we get in the hospital, and that projection is an anterior, posterior, or AP view. So you either ordered it or the patient got a chest x-ray for a reason. So think about it. It would be pointless to expose the patient to radiation and not get accurate information from it that should guide our management. Second, the assessment of the cardiothoracic ratio, or CTR, is supposed to be measured on a posterior, anterior, or PA view, not an AP view where the heart can sometimes be falsely enlarged. Now, if you're looking at an AP chest x-ray, so anterior, posterior, where the x-ray beams are coming from the front and hitting the deflector behind you, the heart does look normal or not enlarged, then the PA, posterior anterior view, will not be larger than that. That means if the patient doesn't have cardiomegaly on an AP chest x-ray, they will not have cardiomegaly on a PA chest x-ray. I hope that made sense. This is further relevant in the context of using the mnemonic RIPE, R-I-P-E. We use that mnemonic to assess our image quality, right? Because if you got a junky image with poor quality, you're going to have a poor assessment or interpretation. But if you look at this, and this is a table that we provide free for download at thisiswhy.health. If you're interested and you want to need something for a study aid or tool, or you want to share it with other learners or use it for a lecture, feel free to do that as a member of thisiswhy.health. But you can see the mnemonic, R-I-P-E, rotation, inspiration, okay, penetration, or projection. And that's what we're talking about here, is understanding this portion of the mnemonic, right, where we're trying to discern, is it AP or PA, so that we interpret things correctly, okay? Now, the RIPE mnemonic, if you remember, okay, my full, more comprehensive how to read a chest x-ray lecture, converges and helps us to understand, do we have an adequate image with good alignment, right? And that's the A to I mnemonic that we use to do our overall interpretation once we've determined that the image is actually a good image. Okay, since the portable AP chest x-ray is done most commonly with the patient lying in bed, their arms are typically at their sides, okay? Going back to our examples here, this is your portable x-ray machine, and that arm can rotate and move and position itself in orientation to where the patient is. And again, most commonly, they are laying in a bed like this, right? Where the head of the bed can be elevated and can be elevated even higher if they're able to do that, okay? Obviously, there's wires, tubes sometimes in the way. Those become things that interfere with our assessment at times. So we want to make sure that we give consideration to the other external things in the way. But the deflector right, or the detector, which is the plate, is actually going to be slid in behind the patient's back. So they lean forward and the plate goes in the back, and the x-rays are coming out of the actual tube towards the patient in an anterior posterior view. Whereas if the patient was able to go into the radiology department, which is ideal, that means that they can stand up, they can hold themselves upright, they can align themselves right, they can take a deep breath. In most cases, they can move their arms if need be. That's a very different position and orientation of how the patient is compared to the two types of images. So when we're talking traditionally about AP chest x-rays that are portable, right, most of the time there are issues with the positioning and sometimes the rotation of the patient. And that's what we're assessing here today, okay? The reason that I brought Bro out here, who's also intently paying attention to this lecture, he's one of my old residents, wore him out, is I wanted to point out what anterior and posterior is, right? So if I put the detector of the x-ray beams behind the patient's back and the tube is coming in, the x-ray beams are coming from the anterior to the posterior, well, that will cause a deflection off of the structures more anterior, and that's obviously where the heart sits. And so when we think about anterior to posterior, remember the plate is sitting here and the x-ray tube, right, is shooting out the x-ray beams towards the anterior portion of the chest, and it's coming back here. Well, if you can notice that if they're laying in bed and their arms are not extended out, that the scapula actually sit in part of the lung field. That becomes very important here in a second when we look at an actual x-ray. But if I turn you, Bro, here even forward, you can see that the scapula make up a portion through the rib lines, because you're having to look through the anterior and the posterior ribs, but you also see the scapula. But if I move the scapula around on each side by changing the position of the arms, I can move the scapula from the view, okay? And that's where a patient now is facing the detector this way, and the x-ray beams are coming in from the posterior to the anterior view, okay? Let's take a look at what that looks like here. Thanks, Bro. So you can see on this image here, again, we have our AP view here, but this is a PA view. And you can see that the patient's arms are in a different position than what you would normally see when someone's laying in bed. They also typically have these handles back here, okay, that you can see, the handles back here on each side that the patient can reach around and grab. And obviously when you do that, the scapula move outward and away from the lung field. And so that opens the lung field up and removes other things. Well, that helps us to see what type of projection most likely this image is if we're not giving that label. Of course, this is a lateral view, and you can see that the patient is, again, lifting up their arms so they're out of the way, because the humerus and other things would be in the way of the chest wall if they didn't do that. But this requires, on a PA view, requires that the patient is not only cooperative, but can follow basic commands and has the strength to stand up and hold themselves up and participate like that, which may not be the case, which is why portable chest x-rays or AP x-rays require some additional considerations as we interpret them, okay? I wanted to reinforce this here on this image so you can again see, just like we saw in Bro, that the scapula, when the arms are down here like this, are in the field of view, okay? That's important to recognize. But if the arms were to stretch, you can pull those scapula out and around and get them out of the view, and again, in more of a PA view, okay? So now let's look at the actual chest x-ray of the patient. And again, you can see that the scapula come around and there's a line going down like this, right? There's the scapula. And so with the scapula being in the field of the lungs, the view, that would suggest, even though the patient's arms are a little bit out, they're not fully extended out of the way, that this patient is possibly more of an AP view, okay? Because again, if they were reaching around to grab onto those handles, the scapula would be moved out further and be more on the periphery of the lung field and out of the point of view, okay? And that's helpful. That is a quick identifier that I use a lot of times in helping me to assess. Plus, I also know the patient who got the x-ray in most cases, okay? I also wanted to take a moment to reinforce the point that I made earlier about the cardiothoracic ratio. Again, this is where we're typically looking at the overall side, the width of the cardiac silhouette and the relationship of the width of the lung fields. If that were to exceed 0.5, okay, or more than 50%, which in this case is not, then this AP, which has a larger heart potentially than is actually on a PA, there's no evidence here of cardiomegaly, okay? So if I did a PA to confirm this, I would probably see that the heart is the same or a little bit smaller. I just want to make sure that point was made, since some people consider that in the overall assessment of, again, am I looking at a PA or AP view, the heart size can change in those two various projections. All right, so key takeaways from this particular topic. One is check for the label on the image. When determining the projection as AP or PA as part of the mnemonic, ripe for determining if that image is even of quality, remembering these things, right? So if an AP view, the arms are typically, in most cases, down by the side because the patient's laying in bed, right? The scapula tend to be occupying and extending over portions of the lung field, versus a PA view, right? The arms typically are extended out and away because they're usually grabbing something like I showed you, where the detector plate is on their chest, and the scapula move out and around, and that opens up the lung fields, okay? Now remember, if you have cardiomegaly or a cardiothoracic ratio of 0.5 or greater on an AP, then you should really get a PA to verify that before you label or suggest the patient has cardiomegaly or even potentially heart failure, especially if this is concerning for a new finding. All right, guys, I hope that you found this to be helpful, and if it was, please consider subscribing to the channel at YouTube, and please give us a like and share this with your colleagues and friends so that we can continue to provide this type of content for you for free. If you're interested, we also have a free membership over at thisiswhy.health, where you can access downloads, images, get coupons and discounts on prep material, ask me questions, access collections, playlists, and other things that are sometimes not found on YouTube. Lastly, if you want to see this topic that I just covered here integrated in the full or more comprehensive lecture on how to read a chest x-ray like a pro, please check out that lecture for that full review for you. Okay, guys? All right, until then, we'll see you later. Take care. Bye-bye.